Welcome back to Endoscopy Essentials. Welcome, Roos Pouw.
Thank you.
And I think we start, how does a perfectly normal Barrett look like and where are the pitfalls? And you have shown us 2 pullbacks last time, but we want to see more.
Yeah, well, I have a lot. So we'll just start with a new, I have a white light pullback for you. Again, with the newest Olympus system. This esophagus has already been cleaned. And as we discussed last time, it's important to get a feeling of the Barrett. Just pull back from the stomach to the top of the
Where are we
Barrett's.
here?
This is, I think, it's a little bit difficult to tell with a still image, but I think we're in the hernia, just above the diaphragmatic
that's stomach,
hinge.
because these are gastric folds.
Yes.
So the narrowing might be the diaphragm, but it's not the beginning of the Barrett again.
No.
Yeah.
No. And this is, if it would move, you normally look at the respiration and see if it moves. But I think we're in the hernia at the moment.
Okay.
So we'll just start the video. Yeah, you see that the
here. Can we
just
stop?
pause
Yes.
it a little.
Yes. So you clearly see the hernia, you see the gastric folds, and you see some color change here, don't you? It's getting a bit more whitish above the gastric folds.
Yes.
Not abruptly, but so that's where the Barrett is a little bit deeper, right? So maybe with more insufflation, the hernia gets pushed down to the stomach.
Yeah. Yeah, I think that's what you nicely see happening here. The esophagus is quite wide and inflated, and you see some color change indeed that crosses the top of the gastric folds as it is now.
Can we go on a little bit and now? So this is a strange Barrett. You don't see the scuriform appearance. It's kind of an atrophic Barrett, right?
Yeah, it's a little bit pale and you see a lot of vessels.
I find these very difficult.
Yeah.
Because they're sometimes the longer you look, the more abnormal it appears. But show us.
Yeah, I totally agree, because we're sort of focused at looking at the mucosal pattern. In these cases, that can be a bit irregular, but here just pulling back. It's a nice Barrett with some squamous islands within. And they advise about a minute per centimeter of Barrett, I think, with the cleaning and pulling back. I think just take your time to inspect everything. Just do the whole circumference. Or focus on one side first and then do another pullback and focus on the other side.
Maybe if you freeze the picture and have a good still image, you have more time to look around.
Exactly. That's what I very often do. Just pull back, make a still image. And sometimes people make an image and immediately shoot it away.
Yes, yeah.
And then it starts moving again. But I think if you freeze it, you have the time to look around. And it's also if you need of course a nice clear still image, not a blurry image. But I think it's actually easier on the eye than when you're looking at something that's moving all the time. And so I think the combination is good. So I often stop like every 2 centimeters in this case, and then you pull back a little bit, stop again, look around, and then pull back.
I love the simple stuff. I love this because it's so important, because everything is moving and you have a hard time really watching details. So still images and go on still images. I love that.
Yeah. Now I think you have to take pictures anyway. So I very systematically take pictures, top of the gastric folds, pull back like every 1 or 2 centimeters. I freeze the image, look around, and then shoot the image away.
But also here you see some vessels in some areas which are more whitish, but they're all normal, right?
Yeah, I think it's just I think the combination of the vessels and the mucosal pattern indicates that it's normal and it's
What
quite
would
flat.
you do if somebody said there's a high-grade dysplasia found on random biopsies? You wouldn't find anything? You would not believe that? So like this at 5 o'clock, is that a little bit more reddish or not? Or
yeah, well, if you have these cases, you scrutinize the whole Barrett and you want to find that needle in the haystack. So if there's nothing really obviously to be seen, then indeed you go for these small areas. So first in white light overview, then go back with a cap on the scope, use narrowband imaging and zoom or near focus to look at the mucosal and vascular pattern. And even if I'm in doubt, but I know that there was high grade before and that's the most ugly thing you find, you usually have a low threshold of doing a resection, just to be sure, or take new biopsies if I'm really a little bit in doubt. Yeah.
Any experience with the new imaging modalities like TXI?
Yeah, so we have them available on the scope. At the beginning when we just had it and it was new, I did use them, but I don't feel that it really contributes to the high definition white light endoscopy. It's such a nice image, and then with the MBI, it complements that I think the TXI, at least for Barrett's, I don't feel it adds a lot.
It's a very personal thing. For example, I'm still, maybe because I'm old, sticking to the conventional image, but one of my colleagues, he loves TXI, so he turned towards TXI. So I think you should try it, and what's best suited. There's no evidence that you have to use it, but it's interesting.
Yeah, and I think it's so easy because you have it available. You just...
So the advice would be play around with it and
that's
see
it. Yeah, play around and see what you personally
okay.
like. And I think that if you use white light, MVI, and then TXA, you look at it 3 times. So you have 3 times more chance of finding something. So that's already a win. I think in this case, I always try to document the top of the Barrett's, because this was a normal Barrett's. So at least there were no abnormal areas in white light. What I then do is switch to narrowband imaging. So there's studies out there that show that MBI doesn't increase detection next to white light. But I do feel that, as we discussed just now, if you look at it twice, you will just find more. So I have a video for that as well.
So now we see NBI.
Yeah, this is narrowband imaging. For MBI, you really want a clean esophagus, because if there's mucus or blood, it's very blurry. But if you clean it very properly, just do another pullback with white light, or with MBI, of course. And again, just freeze the image once in a while. Gives you a chance that the squamous areas stand out much more with MBI, but you can see that you can really nicely see the vascular pattern and the mucosal pattern. And in this case, you would look for irregularities and color changes.
There are a few color changes, but there are these at the 5-6 o'clock. You see these stripes, but if you look at them, they are regular. Yeah. Okay.
Yeah, and you can always go in and zoom in a little bit with your near focus.
Because there are some areas which are a little bit more darker, right?
Yeah, and I have the idea that it might be underlying vessels, maybe more than, because they're very continuous in the whole segment. So
if there's a color change, you go for the surface structure, and if it's normal, you don't suspect anything.
Yeah, yeah. So it's a sort of a combination of things. It's first you do the detection and then the characterization, so to say. And I think, in this case, I didn't see anything that really stood out.
So now comes the crucial question. Yeah. You don't see anything? You don't know that the patient has something, because it's not a referral, it's a routine surveillance. Yeah. Biopsies, yes or no?
Yes.
Yes?
Yeah.
So you don't think what the Japanese preachers, that you see everything, and if you don't see anything, it has a high negative predictive value and blah, blah? No?
I do think that most of the lesions can be found, but low-grade dysplasia, for example, we know that there's a lot of the cases where low-grade dysplasia is really not visible, or at least we don't know how it looks like yet, because the imaging has not been as clear as it is now as for the past years. So especially for low-grade dysplasia, I feel that you cannot easily detect it with endoscopy. And the patients with low-grade dysplasia, they do have an increased risk of progressing to high-grade cancer. So
if it's confirmed.
If it's confirmed by an experienced pathologist. So I think I'm not, personally, I'm not very worried to miss high-grade or cancer. But I will miss low-grade dysplasia. And if the patient has it, I don't want them to come back in 3 or 5 years, because then they might have progressed already. So I do feel that the biopsies, the Seattle protocol biopsies, are still relevant, and especially for endoscopists who don't see that much Barrett's, I think it's just a sort of a safety net to find that high-grade dysplasia or cancerous lesion.
I'm challenging you with that, but you don't have to convince me, because I'm a little bit more image skeptical than most of the people. And I'm not sure whether, if you look at histopathology, high-grade dysplasia is sometimes very subtle. It's in the depth. And whether you really see that at the surface, I don't know. Maybe, maybe not. So still biopsies if you see nothing.
Yes. And biopsy is really safe. But I always say that the imaging is the most important. So don't go do Barrett surveillance to get the biopsies. Do the surveillance to inspect, and then take biopsies just as an extra precaution.
So let's spend a minute with biopsies. They say stepwise biopsies, 4-quadrant biopsies, every 1 to 2 centimeter. And there are 2 ways to do that. You either have at a certain centimeter, 30, 28, you have 4 biopsies around. Or what we do, because I think my personal opinion is it's more relevant for therapeutics if you find something, we try to orient ourselves precisely, and then we do a 12 o'clock biopsy. If the Barrett is not too long, 1, 3 o'clock biopsy, 6 and 9. Yeah. So what are you doing?
Well, I'm still doing circumferential, then in one histology jar, then move up 1 to 2 centimeters and do circumferential. I think your concept is very interesting, but it's very interesting. We just discussed that I mainly take the biopsies to detect low-grade dysplasia, and then I think it's not really relevant in what, if it's at 12 or at 6 o'clock, because if you don't see anything and they have low-grade, I would, repetitively, I would go for ablation and not EMR. But I think it's an interesting concept. I've heard it been discussed before to do, orient yourself and then take the biopsies. I think it's a little bit also what you're comfortable with doing, because you do need to document it properly. That's why the pictures are also very important. That if I get a very surprising, high-grade dysplasia on 40 centimeters back, I can go back to my pictures and then I say, well, this must have been around that area, and then really see if there's nothing abnormal.
Well, we have these occasional cases where there are random biopsies in high grade and you don't see much. So I want to know where it is if I consider resection. If you consider ablation, it doesn't matter. Yeah. So the message is what you do depends very much on the therapeutic consequences. Yes. And if it doesn't matter, you can do whatever you want as long as you take enough biopsies. But if it matters because you have to do a focal resection, you have to know where, then maybe the 12, 3, 6, 9 o'clock concept is better. Yeah. Because then you would remove the whole strip. Yes. If the Barrett is too long, we split it in 2, distal and proximal. So not covering 10 centimeters, 12 o'clock, because then we have the same problem. I think it's a very interesting concept, because it's easier to cut lengthways than to do sort of a centimeter circumferential. Yes, exactly, exactly. But again, you have to be sure what's the plan, what's the therapeutic, what are the therapeutic options, and then direct your biopsies. Okay, so we got some training of how a normal Barrett looks like. It's not a very classic one, so you don't see this piriform appearance. Which is very beautiful and everybody can see it. That was a more difficult one. Yes. I appreciate that. But what we want to learn now is see early cancer, subtle ones. Yeah. So please go ahead. Yeah. So I prepared some slides with a lot of cases, from very subtle to a bit more advanced. And I think looking at a lot of these lesions is very useful, because my mentor always said, you do not detect what you see, you detect what you recognize. So if you know what neoplasia looks like, you know what you have to be looking for. And I think a lot of doctors are not aware how it looks. They look for the bulky cancerous lesions, but those are the lesions we cannot treat endoscopically anymore. So you really want to go for the precursor lesions. So
And-
train your brain.
Yeah, train your brain. Yeah,
Mhm.
it's really pattern recognition.
So we were talking about cleaning last. Is that looks like an insufficiently cleaned area, but it's not.
No, it's not actually. There's some in this case there's some debris on a neoplastic lesion. This is something that you could miss if it's not properly cleaned, and the whitish stuff is on the other side as well. But here it was cleaned.
And insufficient sedation, patient
Yeah.
belching, and
Exactly, and it moves around.
Mhm.
And that this is a lesion. I can point it out with my with the pointer here. But at least this area is abnormal, because it's a little bit irregular, and I think the mucus sort of sticks on the lesion, and therefore it probably was more difficult to flush it away. It's a little bit more reddish also, and you might interpret this maybe as some irritation or inflammation, or as just normal with some mucus, but this is actually a cancerous
But it's
lesion.
very focal because the rest
Yeah.
looks perfectly normal.
Yeah, the rest looks nice. Yeah.
And it doesn't it extend from, let's say, 1 o'clock till almost 6 o'clock?
Yeah, I think maybe this whole here it's a little bit blurry, so you can't say, but I think this whole area here is.
So here we
That's
have
a problem.
all features, because I think the most obvious is the whitish exudate or whatever that is,
Yeah.
that you pick up more easily, and then the reddish discoloration.
Yeah.
You have a central indentation, right?
Yes.
It's not an ulcer, but maybe it was one before PPI. Okay, good.
And location. So we know from studies that the 12 to 6 o'clock position is the area where most early cancers are found, and especially the 3 o'clock position, because there's just more reflux due to the anatomical build of the
Maybe.
stomach.
I'm not sure. I think we're rotating the scope that we see it best, and we rotate the lesion into a certain location. That's what I suspect, and that's where this study comes from, that the lesions are always there. But it doesn't matter.
Yeah, well, at least in your screen, I think you should look at the whole circumference, but the area at the lesser curvature. But we can discuss the data.
Yes.
But there's, at least in this case, it's nicely located there. I think this is a nice example of something that's easily overlooked or misclassified as maybe inflammation. But as you said, the rest looks perfectly normal, and it's very rare to have focal esophagitis within a Barrett segment.
Yes,
Usually, that's neoplasia.
Yes.
So if you suspect it, then you should take a biopsy and not think, just give PPI and see them back.
And then it may heal superficially, so you don't see it again as well.
Yeah.
That's dangerous to give PPI. Take a biopsy.
Yeah,
right?
and especially if the rest of the Barrett's is completely normal.
Yes,
That's
exactly.
a sort of a red flag.
Yeah. Okay.
So another case. This is maybe a bit more pronounced. Also, of course, the image focuses a little bit on the lesion. But it's a small elevated lesion just above the top of the gastric folds. And I will delineate it here. So it's a little bit more reddish, it's a little bit elevated, it's not very big. And in this case, it might be a bit more difficult to detect because it's just on top of one of the folds. And if you don't insufflate enough, it might collapse a little bit, and it might be easily overlooked.
And it can be messed up with a reflux polyp or inflammatory polyp. So again, the same issue as before. So always suspect cancer.
Yeah.
Always for the worst.
Exactly. Always for the worst. Don't give it the benefit of the doubt. Just take a biopsy if you're in doubt.
Yes.
And then pathologist can tell you. And if you see a lesion and you're in doubt and pathologist tells you it's non-dysplastic,
bring the patient back.
Yeah.
Yes. Okay.
Now it's getting more interesting.
Yes, absolutely. That's another atrophic Barrett.
Yeah. So just pausing a little bit, because this is indeed a very clean image. And if you look at it, it's a little bit of an atrophic Barrett's. You nicely see the top of the gastric folds. But there's a very slight depression here. So that's areas you want to sort of be looking at. If you look at the whole of the Barrett's here, you see that something is off. It's quite sharply demarcated. It's a little bit depressed. So that's an area that should draw your attention. You should go in there.
It's very easily missed.
It's very easily missed, especially if you don't know. So if you're watching this and listening to this, and next time you will do Barrett surveillance and you will see something like this, you think, that might be cancer or neoplasia. But if you don't know and haven't seen any examples, this is very easily missed. And I really cannot blame anyone because, it's very, very subtle.
But that's the message is look at that area more closely, right?
Yeah.
Yeah.
Exactly. Because if you go in there with MBI and the mucosal pattern is completely normal, then it's probably nothing. But there's a good chance that you go in there and you see irregularity, mucosal and vascular irregularity, and then you have found the neoplastic lesion. Yeah.
That's a tough one.
Yeah, right? There's another one.
Yeah, it's in the focus, but with some more distance, easily missed. Huh?
Yeah, exactly. Yeah. So this is what we're talking about. And this is a very long Barrett segment. And again, you very clearly
for example, 2 centimeters down at 6 o'clock.
This. Do you mean this?
Yes.
Yeah.
At least you should have a look.
Exactly.
Because it's too far away.
Exactly. Now it's too far away to judge it adequately. Yes. And especially these very long Barrett's without any squamous, they can be a little bit difficult because these patients often have severe reflux as well. And there are more areas that are probably a bit off, but just take your time, inspect them in more detail. And here, for example, you see that this Barrett's also maybe a little bit atrophic. There's a lot of vessels to be seen. But in this area, the vessels sort of disappear because the mucosa is a bit thicker, because there's this lesion overlying. And that are the things that should red flag you and make you want to inspect it more properly. And
also what you said before, this is under full inflation.
Yeah.
Where you see it, maybe if the esophagus is moving and so on, and there's motility, it vanishes. So very interesting.
Yeah, and so this is also then can be helpful just to freeze your image, have a look, and then continue again looking at the moving image. I like the still images a lot to look at the lesions or if there's anything wrong. Another case. The cleaning is of course very important to be able to assess all the mucosa, but sometimes it can also give away if there's a very friable area somewhere that easily bleeds. Also something that should draw your attention because that can be neoplastic and it's not focal esophagitis or irritation if the rest is completely normal.
It's again the whitish exudate which
also,
pulls our view to that.
Yeah, and it's very small. This was a M3 cancer, very small, but it begins somewhere. And this is it draws your attention. Here's another sort of more reddish lesion, but
the red spot at 9 o'clock.
Yeah, but if it's completely flat and this was normal, but it's also something that could draw your. If I would say there would have been a cancer there, you might not be right, but this was normal upon detailed inspection, and this wasn't. So that's the area I took out in the end.
But these images are more important than the close-ups, because when you do a close-up, it's decided that this is a suspicious area, and the main challenge is to pick them up at first sight. Yeah,
exactly. Yeah, and if you know a little bit what you're looking for, it gets easier to find it. It's a little bit of a giveaway because it's nicely in focus, but just to show you that it's very early, small. Like the lesions can be really small as well. So not all cancers are big. they can start really, really small. And also if you look at them under the microscope with your pathologist, it can be just a very small area that's invasive. So you also shouldn't be fooled by it, by saying that's just something small, it cannot be a cancer. Even these very small areas can be invasive.
In fact, our histopathologist started to precisely measuring the cancer in the dysplastic areas. And even if the abnormality is big, the cancer is sometimes very small, 5 millimeters.
That's
So
interesting,
you see a lot of concomitant whatsoever, dysplasia, inflammation, which makes this visible. So that's a tough one, especially from a distance and with a moving esophagus.
Yeah, and in this case it was also, you see it's bleeding a little bit.
Mm-hmm.
And you see that the vascular pattern around it is not visible underneath the lesion. And it's maybe a little bit elevated. But yeah, these are the small things you should be looking at. And also, I tell my fellows, there's no harm if you're in doubt. The first thing is do good photo documentation, like describe where the lesion is, orient yourself at how many centimeters, because they can be difficult to find back sometimes if they're really small. Because once you have taken a biopsy, it starts bleeding, and like taking pictures then is really
pictures before biopsy for sure.
Yeah, and like take just pictures in overview, in detail. I think the pictures are really.
And they're almost never nowadays, with all those saving possibilities. There are almost no situation where there are too many pictures. No. Mostly there are too few.
Exactly.
Yes.
Yeah. Video would also be good, but pictures are just they're good.
Video for location, maybe.
Yeah.
If you see this as very small, difficult to refine.
Yeah. Find it back.
Great.
This is a bit. This is not with the newest Olympus endoscope, but I think it's a nice illustration of the importance of retroflexing as well. We haven't discussed that yet, but when you do Barrett inspection, you should always retroflex your endoscope and look in the cardia area, because it's sometimes difficult because of the angle there to assess that area properly. And in the retroflex position, you can, if the patient is well sedated, they're lying still, it's really safe to pull your scope back in the hernia and have a good inspection there. And in this case, there's a lesion seen here.
Because this one is looking into the stomach and not into the esophagus.
Yeah,
this
exactly.
lesion.
Yeah, it's coming our way, and not these. Yeah. So this you might easily miss if you would just look antegrade. So that's really something, a photo document that area as well. This is another one. It's a bit more clear.
But how far does it extend? You see the whitish elevated area. What's on the left side? Isn't there some irregular area as well?
You mean this area?
Yeah.
Yeah. I think this whole area here, not only the elevated area, but I think this also looks a little bit ugly, glossy, irregular. The vessels are a bit off. So this is this whole area that's looking neoplastic. And this
if you resect this, you should mark the margins wider.
Yes, for sure. Yeah. And then it's also very helpful to do that in the retroflex position, because this area is probably difficult to get close to if you're just looking antegrade. And this way you can, I would place the marks like in the squamous, maybe this also a little bit irregular, to get this whole area out.
Okay.
Yeah. So now we will make it a bit easier. So now we will have white light and MBI images, as you could easily do when you're doing endoscopy, just with the push of the button. But this is again a very early lesion. You can see it's not so big. It's a little bit irregular, again a little bit depressed. There's some whitish exudate, and also in the MBI image you can see that it's a bit more brownish than the surrounding area. So the MBI is, I think, also really helpful for delineation.
But I mean, if you see this erosion, have you seen many erosions in an otherwise normal Barrett? Usually the reflux is up in the squamous epithelium, right? So
Yes.
this is almost always neoplastic.
Yes.
Yeah.
Yeah. So that's very So that's, I think, the focal erosion is almost always neoplasia.
So don't
Yeah.
get away with say, okay, there's a Barrett with inflammation, we give PPI. That's wrong.
That's wrong. Yeah.
Okay.
Yeah. Because they present like this, like erosive, and sometimes if there's just been a recent biopsy, that may also interfere a little bit with what you're seeing. But like focal esophagitis doesn't exist. I think this is also an interesting case because we're talking about Barrett's. And this is just, there's not a lot of Barrett's here. It's a short segment with some extending tongues. But you see that within the squamous part of the esophagus, there's also irregularity. And I think in this case it's
very
even better. Very distally. I think so. With the white light, you would say that this whole area is a bit elevated, and this looks a bit off from the rest. Where you can see here you can see the vessels, and it's nice and the squamous color. But here it's a little bit thicker. There's no vessels here, and I think it's really nice if you have the MBI image. You see that there's a sort of a subsquamous lesion going on here.
Which might be, I think many patients have PPIs, either because they have Barrett's and there's this belief that this will help, or they had reflux and they get PPI first and then they're coming. So you have to be aware that there is something which is healed by squamous epithelium superficially. That's even more difficult.
Yeah, exactly. Because it's not always in the Barrett segment. It can be underneath the squamous.
Yeah.
And then, it's not, I don't think it's, maybe under microscope it's buried Barrett's, but in this case it's very clearly visible that it's abnormal. And if you would want to resect this, you should really take out this whole area, also the whole squamous area that looks.
It looks like an impression, huh?
Yeah.
Above that nodule.
Here.
Yeah.
Yeah. This was in fact. This was removed with ESD. It was an M3 cancer, but with signet ring cells, so a really poorly differentiated lesion.
So this is a Barrett cancer in the squamous part, more or less, most of it.
Yeah.
Yeah.
Yeah. So probably it grew up, or indeed what you said. There may have been esophagitis. He got PPI, healed up.
So again and again, don't say that's inflation.
No. No, only if it's like severely inflamed and you cannot see anything. But
because
otherwise,
the rest is perfectly normal again.
Yeah. Don't cannot get away calling everything inflammatory. No, and especially if sometimes they're already on one dose PPI per day. That's often sufficient not to get severe esophagitis. So
right.
Yeah, if you then double, I don't think they're well.
So the PPI masquerade, that's a very important thing.
Yeah. Yeah, really keep that in mind. And this is another case. This was also quite interesting. So you see, it's a sort of a longitudinal abnormality.
But more in NBI than on the left side.
Yeah, you see it go up.
Of course you did. And the funny thing is you see it on the left side once you have studied NBI.
Yeah.
If you then look back and say, here's the whitish thing up there.
Yeah.
Otherwise, you just have the nodule.
Exactly. And then you start thinking, hey, it might be more than what I'm seeing. So I often go back and forth. It's just a hit, like on your button. It's really easy. Go back and forth, and try to delineate the lesion. And I think in this case, it's really nicely, it's a very longitudinal, but you shouldn't be just focusing on the big lesion, but really try to delineate it. Now, if you start delineating it, you often see that the real abnormalities are more extensive than just the bulk you see. So it's not just bulky lesions we're looking at, it's really also the flat type lesions.
So the training effect here is the upper part of it. So we pretend that the nodule is not there and look at the upper part. And that's really very discreet on the left side.
This area here.
Yeah.
Yeah.
You see it, but you may not recognize it at first.
Yeah. Yeah, exactly. Yeah.
Very nice example. I love that.
Yes, it's nice, right? This was a submucosal cancer. Yeah. That also, so we know from studies that as endoscopists we're not really good at predicting if it's submucosal or mucosal. I have to say, even the pathologists don't always agree. For the pathologists, it's also difficult to say if it's submucosal or not, if it's just, superficial infiltration. But I'm sometimes surprised by the histology.
No, absolutely. I think there were 2 recent studies using images, not live patients, and they showed it to a lot of experts.
Yeah.
But no chance.
No, right? It's just.
But for the resection, maybe that's a different topic. That means that in case of doubt, ESD should be done, right? Or do you think that what did you do here? EMR?
In this case, I did EMR.
And it was
piecemeal EMR, 2 pieces.
Was completely resected basally?
Basically, it was completely free.
Okay.
Yeah, and it was superficial submucosal invasion. It was well differentiated cancer, and no lymphovascular invasion. And I think one of the pieces I resected was just high-grade dysplasia, and the other one contained the cancer, and it was.
And do you know which one, the proximal or the
distal one?
The distal one.
So the bigger one. Yeah, the bigger one. Yeah.
Okay.
So that would fit with our expectation.
Yeah. Okay. Yeah, so we could recognize something, but I mean, there are a lot of lesions like that which are mucosal cancers, the distal ones. Yeah. So you really can't tell. Yeah. But that's a kind of a different topic, and the eternal battle, EMR, ESD. Yeah. We won't fight it here. No. Okay.
Yeah, I think these are the images I had prepared. There's a really nice online module, the board module.
So we put it into the show notes.
Yeah. Yes. Everybody can easily access it for free. And it's just to train yourself with a lot more of these images. How does it look like? How do experts assess these lesions? And I think it's really, it has been shown to improve detection and delineation rates. So, yeah. And I think once you start, I always like doing this. So if you're a little bit enthusiastic and you want to become better, it's nice to look at all these images and to find the
Absolutely, and it's amazing how you train your brain. You will be able to recognize. It's like with other lesions. So I sometimes wonder where the serrated sessile lesions in the colon were 20 years ago. We just didn't recognize them, etc., etc. So great. So thank you very much, Roos, for this super session, and I'm sure we will continue because Barrett is an endless topic.
It is. Thanks.